So we will be transitioning to the next section, and I'm going to introduce James Valentine. He has been working with us to plan and organize the PFDD meeting over the past year. He will be serving as our moderator, and I want to assure all of you that we are in good hands because previously he worked at the FDA where he helped start the PFDD program, and he has organized and led 2/3 of all the externally led meetings. So now I turn it over to you.
Good afternoon. It is my pleasure to be your moderator and to be working with you all for the remainder of our program today to help really build upon the foundation that was just set by our opening speakers, to help characterize the burdens of living with CDD and the unmet needs that exist in hopes that we can design clinical trials and outcome measures that will actually capture things that are important to you, patients and family members and caregivers of individuals living with CDKL5 deficiency disorder. I want to start by thanking Karen for opening the meeting, Dr. Campbell for giving the perspective of the FDA of the importance of this event, Drs. Benke and Demoninsky for giving us the clinical background and scientific background on CDKL5 deficiency disorder, or as you'll hear this community refer to it by shorthand, as either CDD or simply sometimes CDKL5, which is the affected gene. Today is a systematic way for us to gather patient and caregiver perspectives and experiences with CDD, as well as to assess available treatment options. As you heard from FDA's Dr. Campbell, your input can help inform the FDA's understanding of CDD, to help inform drug development and review, which will also be of great value to the drug developers both in the room and on the web today. This is a very unique opportunity to have this type of meeting. As you may or may not know, there are over 7,000 known just rare diseases alone, and this afternoon marks the 32nd externally led PFDD meeting. So I'd like to now share with you, introduce what our agenda will look like for the rest of the day so you know what to expect. We'll start with what are we discussing. Well, we've organized this meeting into 2 topics. The first topic we will tackle is understanding the disease symptoms and health effects of CDD and the impacts that they have on your daily lives. And then we're going to build on that topic by then getting an understanding of current challenges to treatment for CDD. In order to try to understand those 2 topics, we have a few different methods we're going to use together here in the room. We're going to be starting off with each of our topics by hearing from a panel of caregivers. The idea here is each of the caregivers are going to be sharing their experiences on the given topic, setting a good foundation for the discussion that we'll be having with you all in the room. The panelists were selected to reflect a range of experiences with CDD, and we expect to even expand beyond that as we move to those of you that are here in the room today. We'll broaden our discussion after our panels by going to some live polling. So you'll be using your phones, or if you have a tablet and laptop and choose to do so, can use those devices. For those of you on the web, you'll be able to use your home computers or your cell phones if you prefer. And I'll be giving instructions on how to do that. But through those polling questions, we'll be asking some questions to help broaden the discussion, get a sense of the experiences and preference we have represented here in the room and on the web, as well as primarily to aid in our discussion. By having that understanding of the experiences we have, we can then dig deeper with all of you here and get that more context and understanding. So that leads to our third method, which is our facilitated audience discussion. I will be facilitating a discussion with all of our caregivers here in the room, building on this panel discussion and polling questions. I'll be asking specific discussion questions and inviting you to raise your hand to provide your responses, your experiences to those questions. I just ask that when you raise your hand, just wait to be called on. Please state your name if called on, and wait for a microphone before responding. And finally, whether you're here in the room today or on the web, We have an additional opportunity for you to provide input through our survey, which is available on the PFDD website, which is www.cdkl5.com/PFDD. That survey will be available for another 30 days. So if you haven't had a chance to do that, we recommend that you do, because all of today's input here in the room, as well as all of the survey input that we receive, will be summarized in the Voice of the Patient report, which will be provided both to the FDA as well as product developers and just be generally available to the public. Before we go into our first set of polling questions, which will just be on some demographic information, I want to go through a couple of ground rules for today's discussion. First and foremost, I really want to encourage all of our caregivers and family members in the room of individuals affected with CDD to please contribute to the dialogue. This is our unique and important opportunity to hear from all of you, so this is your chance to speak up and be heard. That being said, we have other stakeholders here in the room today. We have FDA officials, we have drug developers, and clinicians. They're here to listen. So they won't be asking questions. I'll be the only one asking questions, nor will they be responding to questions. When you're providing your input, your views are, of course, going to be inherently personal, and the discussion may, given the topic, get emotional. So respect for one another is paramount. We expect that there, as Karen said, there will be both commonalities in your experiences and your preferences, but also divergent experiences. And so we want to make sure that all different views are able to be voiced. And to that end, we do ask that you try to be focused and concise in your comments, so that way we can hear as many voices as possible in the limited time that we have today. So with all of that, let's go ahead and get started. Go ahead and pull out your phones or tablets and laptops. We're going to go to our set of demographic polling questions, get a sense of who is participating in our meeting today. So if you go, it's displayed on the top of this slide here, but if you go to the website, www.pollev.com/CDKL5, you'll be able to access the polling questions. This is for our family members and caregivers only, please. And if you're having any trouble accessing the polling, please raise your hand and one of our team members will come and help you access that. So this is for all of our caregivers here in the room as well as following along online. Please raise your hand if you are having any difficulties. So we're going to go through these questions fairly quickly. They should be easy. The ones that come a little later in the program might be a little bit more difficult and require more thought. But here we want to know, where do you currently reside? Your options are A, the U.S. Northeast, B, the U.S. Midwest, C, the U.S. South, D, the U.S. West, E, the U.S. Pacific, F, Mexico or Canada, or G, if outside of North America. And again, this will include all of our in-person as well as web participants. Was there a question or an issue? Could someone assist right here in the middle of the room? Ed, or, yep. Just give me a thumbs up. So today we'll not be able to break out who is in the room versus on the web, but given our current results, I'll go ahead and start sharing those. So perhaps not surprisingly, given the physical location of our meeting, we have greatest representation, about a third of our participants being from the U.S. Northeast. However, we do have good representation from across the U.S. We have representation from the Midwest, the South, the West, as well as the Pacific. Interestingly, we also have good representation from out of the U.S., perhaps a signal to this international patient community that exists and the fact that they may be following along online. So if we can go to our next polling question. So this question is, do you live in an A, a city, B, a rural area, or C, a suburban area? Just give you a few moments to respond to this question. So it looks like just about half of our participants today live in suburban areas. A little under a third of our participants, or around a third, live in a city. And then we do have some representation, about 10%, from a rural area. Go to our third demographic question. So this question, please respond whether your child is A, male, or B, female. And although our questions are all worded to be about your child, if you are a grandparent or a sibling or other caregiver of an individual CDD, please respond for that individual. So it looks like just about 80% of the individuals with CDD that we have represented by their caregivers here today are females, and about 17% of individuals are male. We go to our next polling question. So here we would like to know, what is your child's race or ethnicity? The options are A, American Indian or Alaskan Native, B, Asian, C, Black or African American, D, Native Hawaiian or other Pacific Islander, E, multiracial, F, white, or G, other. Please select that which best represents your child's race or ethnicity. So while final results are trickling in, it looks like our largest representation, about 80%, are white. After that, we do have representation from multiracial, Asian, and African Americans, as well as some other race or ethnicities not listed on the slide. Does not look like we have representation from American Indians or Native Hawaiians or other Pacific Islanders. Next question. This question is, at what age did your child have his or her first seizure? And the options here are A, was the first seizure within the first month of age, B, between 1 and 3 months of age, C, between 6 and 1 year of age, D, between 1 and 2 years of age, or E, after 2 years of age. This is the age of first seizure. Final results trickle in. It looks like the greatest experience of our individuals with CDD represented today are seizures within the first month of age, a little over half. We have then about a third that had their first seizure between 1 and 3 months, and then about a little under 10%, between 5 and 10%, between 6 months and 1 year. No one reported having a first seizure between 1 and 2 years, and we had some small representation of those who had their first seizure after 2 years of age. Next question. So this question is at which age was your child diagnosed with CDD? And so the same age response options are A, before 3 months, B, between 3 and 6 months, C, between 6 months and 1 year, D, between 1 year and 2 years, or E, after 2 years of age. So this was the age of diagnosis with CDD. So as the results are trickling in, I think as you compare our responses to the last question of time of first seizure to this, the time of diagnosis, you're seeing almost an inverse response rate with the greatest response here being diagnosis after 2 years of age, and the least or the lowest response rate being before 3 months of age, whereas that was flipped for time of first seizure. And can we go to our final demographic polling question? And now we'd like to know, how old is your child today, presently? A, less than 1 year of age, B, between 1 to 2 years, C, between 3 to 5 years, D, between 6 to 10 years, E, between 11 and 18 years, or F, greater than 19 years of age today. So given that there were so few that were diagnosed within the early months of life, perhaps it's not surprising that we don't have any individuals represented for less than 1 year of age currently. Our greatest representation is individuals aged 11 to 18 years, followed closely behind those both between 3 and 5 and 6 and 10 years. Also good representation in those aged 1 to 2. And we do have representation of those older than 19. So thank you very much for participating in our demographic polling. Always good to get a sense of who we have represented both in the room and on the web. At this point, I'll invite our first panel to the stage as we transition into our first topic for this afternoon's discussion. So panelists, don't be shy. Come on up. So our first topic, we're going to be discussing symptoms and daily impacts of living with CDD. So here we're going to be, through our panel discussion as well as our polling and audience discussion, exploring those symptoms and health effects of CDD that have the greatest impact on you and your children. We want to understand how those different symptoms and health effects impact activities that are important to your child and for your child, how those impacts might change and vary, whether that be day to day, week to week, month to month, or over the course of years, the progression of the disease. And we also want to know not just the impact for today, but also what it is that worries you most about the future for your children living with CDD. So to get us started on this topic, we have a great panel for you. We have Deanna, Jenny, Marissa, Kathy, and Rick, who are going to be sharing their and their children's stories. So I'll ask Deanna to go ahead and kick it off for us.
Imagine waking up each morning not knowing if you'll be able to see, hear, walk, talk, or eat that day. Oh, and you're living on a sailboat in the middle of the Atlantic Ocean in the middle of a storm. Welcome to life with CDKL5 Deficiency disorder. My name is Deanna. I am mom to 17-month-old Lena Isabel from Front Royal, Virginia, and our family has been braving the stormy weather for about 14 months. Lena started having seizures before she was 5 weeks old, and at the age of 3.5 months, she was diagnosed with CDD. We were given a grim prognosis. Not only will she likely never walk, talk, feed herself, or achieve seizure freedom, but her life itself may be at risk. Despite this, she continued to develop, rolling, holding her head up in tummy time, cooing, and tracking and reaching for certain objects. We were encouraged and dared to hope until about 6 months in, when progress came to a halt. Lena spent weeks in a constant state of lethargy and irritability, not utilizing her skills or interacting with us. Eventually, some of her personality and skills resurfaced, but not for long. Another period of similar loss occurred a few short months later. Currently, we're on the 3rd iteration of skill acquisition, and she's working hard on her vision and motor skills. Our family focuses a lot on skill acquisition because Lena's cortical visual impairment, her fine and gross motor skills deficits, and her profound intellectual disability were the things we thought had the biggest impact on her quality of life. Lena's inability to see means that she's not motivated to reach or to move towards a goal. She does not make eye contact or interact visually with the world around her, which makes it hard for her to connect socially. Her motor deficits mean she cannot enjoy the textures and sounds of objects around her because she cannot reach them if they are outside of her immediate vicinity, nor can she hold them unless they have very specific shapes and sizes. More importantly, her intellectual disability makes it hard for her to help us understand her needs and to navigate her world by learning and applying knowledge. For instance, if a toy drops from her hand, it may as well have fallen off the edge of the world. She does not appear to miss it once it is gone or reach for it to get it back. Sometimes I wonder if she feels the same way about me, her own mother, when I leave the room. I used to think that life would be immeasurably better if any or all of these abilities could be improved. However, recently things took a turn that made me question everything I thought I wanted for her. In short, Lena stopped eating. She was always a great eater, and even on other occasions when we struggled, she never flat out refused to open her mouth. However, this time she stubbornly pressed her lips shut every time I approached her with a bottle. We were not sure if this is because of teething, severe constipation, or the progression of the disease, and we realized later it was surprisingly related to her treatment management. Regardless, it landed us back in the hospital. At this point, our priorities shifted considerably as we are reminded that life preservation itself cannot be taken for granted in CDD. I do not care anymore if she meets her therapy goals, if she's able to make eye contact or even hold her head up. All I want is for her to eat, or at least drink a little water. Having to constantly choose between priorities, goals, and targets has been destabilizing for our family, both emotionally and strategically. We cannot focus on developing her vision when she's screaming in pain from constipation. We cannot work on eating solids when she will not drink water. We cannot read or play with her when she's disconnected from the world around her. Every treatment decision that we make seems to have detrimental effects in other areas. We chased seizure freedom by meddling with her medication and medical diet, and we obtained it temporarily at the price of refusal to eat or drink. The weekly blood draws she has to endure revealed that this refusal led to acidosis, hypoglycemia, and hyperketosis. We learned that seizures are not the most harmful aspect of her condition, as on many seizure days, she's still energetic and playful, while she paradoxically spends some seizure-free days sleeping or fussing. Our new goals sound something like this. We would like for her to function at the highest level possible from a visual, motor, and intellectual point of view and have the fewest possible seizures, but only if this does not affect life-sustaining functions. Sounds super simple and feasible, right? Looking at our past experience and our future goals, it seems that instead of moving in a forward trajectory, we travel in circles. Sometimes we circle forward, sometimes backward, but I invariably recognize the places we're passing as places where we have already been. We are not sure what will happen tomorrow, which makes it very hard to plan or develop expectations. Although he didn't know it, when the Greek philosopher Heraclitus said change is the only constant in life, he was describing life with CDD. Thank you.
Thank you for the opportunity to be here today and share our story. My name is Jenny Feynman. I live in Greenwood, Indiana with my husband, Steve. We have 3 children. Nicholas is 14, Hannah is 12, and Allison is 7. 3 weeks after a typical healthy birth, our youngest daughter, Allie, suffered through 11 seizures in one day. Over the next 4 months, we frantically searched for answers as the seizures could not be controlled. Finally, after a full spectrum of genetic testing, we received the official diagnosis of CDKL5 Deficiency disorder. At that time, we were told there were only 900 confirmed cases of CDKL5 in the world, and unfortunately, there was very little information to help us understand what this diagnosis meant for Allie and for us as a family. Fast forward through many more ER visits, doctor consultations, and numerous EEGs, Allie's neurology team told us that we would have a very difficult time controlling her seizures with medication. Her test results showed that she was at risk for every type of seizure, thus turning any medication and the side effects into a game of chance. We tried our best to keep diaries of her seizure activity, hoping somehow we would unlock a secret pattern that could be used as a pathway to treatment, but no such luck. Allie's seizure activity started as 3 to 4 one-minute-long episodes each day, with most occurring during the day. By 7 months old, her seizures became a little less frequent, but longer in duration, having a couple more per day but lasting 10 to 13 minutes each, and would often happen in the middle of the night. By 8 months old, Allie was having one long seizure every day lasting 15 to 20 minutes. They seemed to be at their worst when Allie fell asleep, and she would wake up screaming as if in excruciating pain. The screaming associated with these episodes was incredibly alarming to us as her parents, and even more terrifying to her brother and sister. During this time, the lack of normal achievements became glaring. Allie wasn't smiling, there was no visual tracking of objects, she would not even grasp her toys. She would not engage. Our beautiful daughter would not even look at us as we held her. Looking back on the first 2 years of her life, we thought the worst was behind us, but we were wrong. Round 2 of CDKL5 begins. We adapted, if you can call it that, to life with seizures. But when Allie was 3, she started significant crying and sometimes even screaming spells. Uncontrollable and inconsolable screaming and whole body thrashing. This period lasted several months. Her doctors thought this was a new form of seizure activity, but medicines were not making any difference. We again did our best to adapt. Keep in mind, we are a family of 5. God love our other children, as they endured many family dinners with sounds of their sister screaming in the background, and many, many sleepless nights. We would have to remove Allie from the room just to try and have a conversation. As a parent, this was heartbreaking. Once it reached the point that Allie stopped eating and would barely drink, we drove to the ER and said, "We're not leaving until someone can tell us why our daughter seems to be in so much pain and now won't eat." During the exam, they couldn't find anything of significance. It was upon reviewing a whole body bone scan that they saw a small glimpse of her stomach and that it was significantly impacted. After numerous stool softeners, laxatives, and enemas, Allie finally got some relief. 13 diapers later, the screaming had stopped, and we could once again find some reprieve. Allie had gotten back to, quote, normal baseline, and we were able to sit together as a family and enjoy quiet conversation. As you can see, there are many facets to CDKL5, but there is another side to this disorder that is often a secondary concern. As caregivers, we are subjected to unimaginable mental and physical stress. We want the best for our children and spend every minute trying to figure out how to make it better. The mental fatigue combined with the physical stress of caring for an immobile child and the many sleepless nights definitely takes a toll on the body. Earlier this year, I was diagnosed with a cardiac issue known as PVCs, which are increased irregular heartbeats. I was told this condition was the direct result of stress and lack of sleep. Fortunately, I was able to have a surgery which involved cauterizing several areas of my heart, and am back to normal heart health. If this is how my body reacted to the stress effects of CDKL5, can you imagine the amount of stress Allie's little body faces every day as a result of her seizures, GI complications, lack of sleep, and sensory issues? 7 years into our journey with CDKL5, and we are still searching for answers and learning to cope. As we experience and deal with one symptom, another is not far behind. For every new symptom brings the challenge of how to provide relief and maintain comfort. The unknown aspects of Allie's future are difficult to contemplate. Aside from the obvious questions concerning development, will she ever walk or even take one step? Will we ever hear her little voice? Will she ever engage with us? But the most pressing question is, how long will her body endure the torment of CDKL5? Thank you.
My name is Marissa Bishop, and I have a sweet, beautiful 3-year-old son with CDKL5 Deficiency disorder. His name is Gregory, and we live in Connecticut. Like many of the parents here, I remember the day that Gregory had his first seizure. It was the same day that I took his 1-month baby photo. I was holding him, sleeping, outside on our deck, when suddenly all 4 of his limbs were jerking. And by the time I got the pediatrician on the phone, it had ended, and he said to let him know if it happened again, and of course it did. Gregory was diagnosed with epilepsy at 2.5 months old, and we learned of his CDKL5 diagnosis at 6 months. That first year of his life was emotional. Gregory is our only child, so my husband and I were both adjusting to being new parents and navigating what it meant to have a baby with multiple health needs. Our baby had daily seizures. His low muscle tone meant that he struggled significantly with the most basic of gross motor tasks. He couldn't lift his head, he couldn't reach, he was functionally blind, and he needed his bottles to be thickened in order to drink them safely. As he grew, Gregory never officially met any milestones, but he did make progress. Around age 1, with the help of his vision teacher, he started peeking, first at red things and then at yellow things. Later on, with physical therapy, when given proper trunk support, he was able to keep his head up in midline for a few minutes on a good day. And around age 2, if you set him up just right, he was able to prop sit for a few seconds on his own. Lately, I find myself wondering, despite how challenging those early years were, if they will be Gregory's best years. In 2019, we have struggled. In January, Gregory got sick, a terrible double ear infection and upper respiratory infection that took 3 rounds of antibiotics to clear. He was so sick that he was unable to suck from his bottle, and he lost and never regained that skill. Because he wasn't able to drink from any cups, suddenly his feeding challenges became a lot more difficult as I struggled to get enough fluids into him by spoon feeding his purees. Then in March, his seizures became completely out of control. He started having tonic seizures that went into clusters of spasms that were so intense and prolonged that he would sleep for hours after each one, and he was averaging 9 a day. For weeks, it seemed that all he did was seize and sleep. Gregory's alertness was so compromised that he wasn't strong enough to eat by mouth, and over time, he lost that skill too. Right now, Gregory is 100% fed via G-tube. No longer can he prop sit or keep his head up, even with trunk support. Right now, he can't even lift his head up off his chest. We struggle with how to position him properly so he can engage with our family or work on his vision or other therapies. But currently, our biggest struggle is Gregory's respiratory health. We've taken 2 ambulance rides to the hospital for acute respiratory distress. Gregory's weak cough and his improper swallow contribute to his respiratory issues, as he isn't able to successfully clear secretions from his airway. He desaturates daily and needs to be connected to oxygen for varying lengths of time. Gregory sometimes vomits with his seizures, so I rarely risk taking him in the car by myself. From that first cough that indicates he's about to vomit, I really only have seconds to safely pull over and get to him to try and prevent him from aspirating. This year has shown me just how significant Gregory's CDKL5 diagnosis is, and I have no doubt now about its ability to be a life-limiting diagnosis. This past summer, I'd made a bucket list of simple things I wanted to do with him, like have a picnic and go to the beach, but we barely checked anything off. Unfortunately, the desire to get out of the house is usually overshadowed by the stress of actually being out, so we often choose to stay at home. CDKL5 deficiency disorder has made life incredibly challenging for Gregory and for our family, and I worry about him all the time. I'm worried he won't regain the skills that he has lost, worried that even worse seizures are around the corner somehow, and worried that his ongoing respiratory issues will cause irreparable damage to his lungs. And I also feel stressed because the majority of his caretaking is done by me, stressed that he needs to find private nurses to babysit because grandparents can't do it anymore, and our private insurance doesn't cover any nursing. And stressed that Gregory averages 25 seizures a day, and about 5 of them happen overnight, so he doesn't get healthy, restorative sleep, and neither do I. My son is strong, but he is fragile, and he is 100% dependent on others to keep him alive. My hope is that the future will bring advanced treatments that get to the root of his disease, and that this will allow Gregory to learn and to be as healthy as possible so that we can enjoy our life together much more than we are currently able. Thank you.
My name is Kathy DeSimone. I'm from Wisconsin, New York, and I'm the mother of my beautiful 10-year-old daughter named Caitlin Amber DeSimone. She's a happy little girl, and she's the light of our lives. I first noticed Caitlin making movements like the Moro reflex, but sensed and said something was very wrong. Caitlin's first seizure was when she was 5 weeks old. She was having up to 7 seizures a day. They only lasted a few seconds, but they were quite forceful. Her seizures continued uncontrolled, even with a phenobarbital level of 52 at 6 weeks of age. At 8 weeks of age, we admitted her back to the hospital because she had no quality of life, sleeping 22 out of 24 hours a day. We were finally able to bring her home, but with no diagnosis. I remember placing her completely limp little body in her newly decorated pink nursery. I was shocked to see the difference in tone, and I wondered if it would ever come back. She was finally diagnosed with CDD at about 26 months of age by Boston Children's Hospital in Massachusetts after genetic panel testing. As horrible the diagnosis was, it was an important step forward for her future care, meaningful treatments, and perhaps even a cure. Her seizures continued uncontrolled and brought on other debilitating symptoms. Lack of seizure control is devastating, and it negates any small gains she may have had. She would have periods of seizure freedom that could last several months, and during those times, Caitlin was sitting independently, transferring objects from one hand to another, and sipping from a straw. She was gaining skills, albeit very slowly. However, at the age of 4, and after a month-long hospital stay due to status epilepticus, she lost all those skills. We have found that uncontrolled seizures bring on more debilitating CD symptoms and affect the gained skills. Once the skill is lost, it is very difficult to gain back. Caitlin's extreme hypotonia is brought on by her uncontrolled seizures. My daughter's core is like a wet noodle. She's also showing signs of a curve in her spine, and I fear scoliosis may be in her future. Caitlin goes to school every day with a private duty nurse. In addition to monitoring her daily seizures, the nurse positions Caitlin several times a day to protect her spine and pelvis. The nurse is our peace of mind while my husband and I are at work. Caitlin was recently diagnosed with pre-osteopenia, and she now needs to be followed by a pediatric physiatrist and endocrinologist for treatment. This would be in addition to being followed by our pediatrician, neurologist, gastroenterologist, orthopedist, and nutritionist. Low tone on the outside also means low tone on the inside. Recently, she's been having problems clearing her secretions, particularly in the back of her throat. During a recent coughing incident, she choked on her own phlegm, and it blocked her airway. She could not maintain her oxygen level, and this resulted in an ER trip, which later turned into an admission when she was not able to breathe room air. Treatments for total seizure control would be life-changing. My daughter is unable to communicate with me. Hand coordination or purposeful use of her hands prevents her from telling me what her needs are. I must guess if her crying stems from pain, hunger, or discomfort. Recently, she cried on and off with tears at school, which is very unlike her because she's always a happy child. The nurse felt she was in pain. When I examined her, I narrowed the pain down to her leg, but I could not tell if it was her whole leg, ankle, or knee. X-rays were taken and nothing seemed to be broken. However, it was obvious from her wincing she was still in pain. 3 days later, after another X-ray, this time dedicated to her foot, a hairline fracture was found. It's an indescribably sickening feeling that I'm not able to ease my child's pain. Or it's delayed because she can't tell me exactly where she's hurting or how it happened. There is no greater feeling of helplessness when a parent cannot help their child. She needs to be fed, bathed, and dressed by a parent or nurse. She's not toilet trained. And she needs to be carried to and from her bed or bath, which is back-breaking work after doing it for 10 years. My husband and I both work full-time, and our care is a taxing second job. But we do what we do for the love of our child. This is what keeps us sane from this disorder, has stolen so much from my daughter and us as a family. To date, This has been a very difficult journey, and we must bear down even more. So if her situation worsens, we have become well-versed in all types of durable medical equipment, including wheelchairs, standers, cough assistant machines, suction machines, nebulizer. We're getting a handicap accessibility for her room and bathroom to include a ceiling lift and a walk-in shower. An accessible wheelchair van will soon follow. We will need to think of special needs, trusts, and wills for Caitlin's future, so we know that she will always be taken care of, especially when we're no longer here. Thank you.
My name is Rick Up. My wife Cynthia and I live in Spokane, Washington, where we've raised 5 children. Our 4th child, Olivia, is now 17 years old. Olivia began having seizures when she was 2 weeks old. By the age of 6 months, it was already clear she wasn't meeting milestones. She was diagnosed at various times with infantile spasms, atypical Rett syndrome, and Lennox-Gastaut syndrome. We did a genetic panel when she was young, but the test didn't include what turned out to be her real disease. It wasn't until on her 11th birthday that she received the correct diagnosis, CDKL5 Deficiency disorder. In addition to the ever-present seizures, the primary issues that Olivia suffers from are limited mobility, cognitive and communications impairment, and gastrointestinal problems. GI issues have recently become a big deal for Olivia, and it started with a cough. Until just this year, she would often guzzle down a full cup of water in one go, give a little cough, and then ask for more. This year, we noticed that the little cough was growing into little coughing fits, and they were getting worse. A swallow study revealed that she was aspirating liquids when she drank, and probably had been doing so for some time. Apparently, the only reason she hadn't suffered pneumonia is her insistence on drinking only water. Turns out her simple Epicurean tastes had kept her out of the hospital. But her worsening aspiration meant even water was becoming a danger, not to mention solid food. So she had a G-tube surgically installed this summer. The other GI issue is constipation. This issue is not new. Most of Olivia's life has been a roller coaster swinging between constipation and diarrhea. Olivia has landed in the hospital with acute constipation several times, and anyone who's ever played Oregon Trail knows the dangers of diarrhea. So every day we would walk the fine line and second-guess ourselves about the quantity of Miralax to administer. When Olivia was having her G-tube inserted, the doctor suggested also having an appendicostomy so we can administer enema fluid straight to the top of her colon. New procedure, same question. How much do we give her tonight? It seems like with every new treatment, there's a new source of anxiety. Another way that CDKL5 impacts Olivia is by limiting her mobility. Olivia was lucky to be one of the CDKL5 kids who could walk, and she loved it. One of her favorite activities was to go to the mall and walk or even run down the aisles. It was a challenge for us just to keep up with her. Sadly, in recent years, she's become more and more unsure in her steps. Walking is very limited. She falls frequently. And running is nothing more than a memory for us. Can Olivia remember running? Can she remember racing through the mall? Part of me hopes she can't. Still, I think in her dreams, she runs. Olivia's impaired mobility limits more than just trips to the mall. Her bulky stroller, really a type of wheelchair, makes it a challenge to take her into crowded spaces. It was a difficult and sad decision not to take her to our church's Halloween party this year. In past years, we'd just taken her hand and walked her through the displays. This year, we knew she'd be confined to her stroller, and the thought of pushing that through the crowd of young children is daunting. Finally, I want to tell you about Olivia's cognition and communications. At 17, Olivia thinks and communicates at the level of a 1-year-old. But she can still learn. She loved her special needs class at the junior high school. Then when it was time for her to move up to, at the junior high school rather, then when it was time for her to move up to high school, we went to a meeting where her new special needs teacher explained how the program was focused on things like life skills, learning Washington state history, etc. There was no program in that district for children of more limited skills. My wife left the meeting in tears. We sold our house and moved to a better school district for Olivia. At one time, Olivia had a vocabulary of about 10 or so words. Some of them made up, like psh, which means bus, the sound the air brakes makes. Her favorite word was mom. I've only heard her say dad twice. Imagine going 17 years and hearing your child say dad twice. Daddy, not even once. Unfortunately, whether it's the effect of the anti-epilepsy meds on her brain or the effect of the seizures themselves, she's lost the ability to speak almost entirely. One of the words she held on to the longest was Bieberber, which the parent of any toddler will tell you means a McDonald's cheeseburger. She would shout out Bieberber and squeal with delight when the car turned into the drive-thru. She was looking forward to that cheeseburger, of course, but I think she was also excited because she felt like this was one area of her life that she could control. In fact, out of control probably describes life with CDKL5 better than anything. What would help us feel more in control? Controlling the seizures, of course, and the GI problems, both the aspiration and the constipation diarrhea roller coaster. But most of all, I wish we could free her brain from the cognitive impacts of CDKL5. There's a sweet, loving, amazing girl just locked in there waiting to get out. I could list 100 effects CDKL5 has had on our family, but I'll close with this one. Recently, Cynthia and I were talking to our oldest daughter, Emily, about providing guardianship for Olivia once we're gone. She said, "Don't worry, I've already decided that when I get married, I'm a package deal. Even if that means I don't get married, Olivia stays with me." A young woman in the prime of her life, giving up everything to care for her sister. That's the best and the worst of CDKL5 all in one. Thanks.
This panel has been incredibly brave to sit here in front of you and share their stories and really break the ice. So join me in a round of applause for this panel. Thank you. So now we're going to open the discussion up to the audience through a series of both polling and discussion questions. So throughout the rest of our first session here, we're going to be going to your phones to do some polling questions, and then we'll follow up with some discussion. So if we can actually go to our first topic 1 polling question. So we're going to have 2 back-to-back polling questions to get us started, and then I want to dive in and get some input from our audience here. So this first question is, which of the following CDD-related symptoms and health effects does your child currently have? And please here select all that apply. So our options are A, for epilepsy seizures, B, difficulty walking, C, global developmental delay, D, scoliosis or curvature of the spine, E, limited hand control, F, visual impairment, G, limited or absent speech, H, GI and feeding problems, I, respiratory problems, J, behavioral disturbances, K, sleep problems, or L, some other symptom or health effect not listed on this slide that's related to your child's CDD. The percentages that you see displayed are a percentage of the number of responses, not the percentage of individuals that have that particular symptom. So I'll give you a few moments to please select all that apply. Okay. So while some final results are trickling in, I think one thing that is apparent from your responses here is the large range of symptoms and health effects that are experienced by so many individuals with CDD. Going down the list, just some of the top ones are seizures and epilepsy, difficulty walking, global developmental delay, limited hand control, visual impairment, limited or absent speech, GI and feeding problems. Close behind some of these is respiratory problems, but also behavioral disturbances and sleep problems. Even scoliosis and other symptoms that aren't listed on this slide are rated fairly highly by our group today. Is there a question?
Can you just explain, because I think, is it that all of them would add up to 100%?
So again, there's a question in the audience for those of you on the web about the percentages. So again, this is the percentage of responses. So since everyone could select all that apply, you're seeing a percentage of total responses. The way to really interpret this is to look to see how large the bars are relative to each other. We'll be able to, after the fact, go back and see what percentage of individuals selected each different response. So the fact that we see so many bars that are all to the far right show that there's a high burden of these different symptoms and health effects across many individuals represented here today. Can we go to our second polling question? So these response options will look familiar since they're exactly the same as our prior question. So here, instead of selecting all that apply, we want you to select the top 3 CDD-related symptoms and health effects that are most bothersome for your child. So here, select the top 3 of all the symptoms and health effects that your child has that provide the greatest burden to them. And it's the same options as before. And similarly, the percentages are a percentage of responses. Okay, I'll give you just a few more moments to get in your responses. As it stands, the symptom and health effect that you all are reporting as being the most burdensome, or one of the greatest of the top 3 burdens, is global developmental delay. After that, we have epilepsy and seizures, followed closely by GI and feeding problems. However, no symptom listed here was not selected as a top 3 most burdensome symptom by some number of you. So that's showing that for each individual, the things that might be impacting them most in daily life are different from one another, even with some that may be rising to the top across the group. And so that's going to be really important for us to explore now, and we can keep these responses up. But I want to now ask, we have 2 mic runners in the room, so I want to invite you to raise your hand, and if called upon, just state your name. There's, oh, I know, yeah, thank you. I was getting the signal in the back, but so we're going to discuss this topic a bit before we go to our next polling question. I've just asked you to think about and select the top 3 CDD-related symptoms and health effects that are most burdensome. But now what I want to do is understand why you made the selections that you made. We heard from our panel some of the things that have been most impacting their children, but I want to hear from you, thinking about the top 3 things that you just picked, perhaps even thinking about the top number 1 symptom or health effect. Why did you say that had the greatest burden on your child? Would someone like to share their top burden? Yes, we'll start right here in the middle, and then we'll come right here to you.
Hi, I'm Melissa. This is Haley.
Hi, Melissa.
So we chose global developmental delay,
Yes.
limited speech, and GI problems. And
Yes.
the reasons behind that, I mean, speech, Haley is very trapped. She's,
Yes.
I think, more cognitively aware than she's able to express. And I think the global developmental delay goes along with that. I think for Haley, seeing other children, her cousins, playing and not being able to interact with them is probably, it's for us one of the most difficult things, and I think for her as well. The reason I didn't pick seizures mostly is because, well, they're extremely bothersome for us. They aren't for her. And I think that's very important. Seizing is a part of her life. It's like blinking is for us. And I think it's important, yes. I think it's important for us to recognize that seizures are normal for them. It's the other stuff that's more difficult.
Sure.
So.
Yeah, thank you very much. And that was thank you for sharing, the example of, playing with her cousins being kind of the thing that frustrates her. And those types of examples are exactly what we'd like to hear today. But yes.
Hi, my name is Rita Fredericks, and this is my family, Miles, Liam, and Nathan. And as we were picking our top 3 choices, we focus a lot on the fact that Miles does not have a communication system, no way to have expressive or receptive communication. His cortical vision and hearing impairments are greatly impacted by his CDKL5 diagnosis and the dysfunction of his neurological system. He's not able to understand, or we're not able to communicate with him what's happening to his body and what he would like to happen to his body, or what he would like, what activity, what he would like to stop, what he would like to continue. And that is very difficult for our family. We, and all of his caregivers and providers in school and at medical daycare, we'd like to be able to communicate and express to him what's going on around him, and we'd like to hear what he would like to do.
Yeah. And can you give me an example of when that disconnect, really is frustrating or most burdensome?
Sure. Prior to knowing that he was deaf and blind, we were swimming with him, and he really enjoyed swimming, but we didn't understand why he didn't enjoy bath time then. And he didn't know that he was being plunked into this tub of hot water, and that was alarming to him. And we learn now, and we have a routine and a system, and that helps him. But prior to knowing, we're just moving him from place to place,
Yes.
in and out of equipment, putting him, just inserting him into activities, and whether that's water, sand, the floor at home, car seat, and he can't tell us, I don't like this sand. I don't like the way that feels, or that water doesn't feel good to me, that's too hot. And so, it's very limited to crying. And of course, it's hard to always know what that means.
Yes. Thank you so much for sharing.
Yes.
Who else would like to share some of their thoughts behind what you selected as being most burdensome? Yes.
Well, we selected also global developmental delay and visual impairments, and then I shared with my husband, one of us put gastrointestinal and feeding problems, one of us put sleep, because for us those two are both very important. But I think the global developmental delay probably takes the primary spot, and for me, not only I would like to know what Lena likes to do, but also what's bothering her. So many times when she's crying, I end up asking a list of questions. Does your head hurt? Does your tummy hurt? Are you hungry? Are you sad? What's going on? And sometimes she will stop crying when I reach some option, and I'd like to believe there's a connection, and that when I reached the right answer, she stops. But I don't know if she understands. I don't know if she makes that connection. And we do try to address everything that we could possibly think of that could bother her, but I would love to know, for her to point to her tummy, or to smile if I got it right, or to show me that she's connected. So if we could somehow unlock the door that keeps her trapped, is a good word that I heard here today, we would be very, very grateful.
Yeah. Thank you so much, Deanna. So others, we'll take Karen.
So I just want to say, for Samantha, silence always means yes. So keep encouraging that type, because that is communication, right? If you can just stop talking or stop making noise. But I will tell you, the top 3 were hard for me to pick, but seizures wasn't even in probably the top 5. But this is not one I picked, but no one said anything yet, where you briefly mentioned sleep. But I've laughed and said, Samantha's conditioned me. I can go like 3 days with just a few hours of sleep. But I think that is another really big issue, that if we could somehow just figure out a way to help repair the circadian rhythm in these kids to where families could get a decent night's sleep, then you can also face everything else much more fresh and ready for those challenges.
Yeah, so I'm going to probe then a little bit on the
Okay.
topic of sleep with you. Is this, what are the impacts? I mean, I think we have some general idea that lack of sleep is not good, but what specifically is the impact of, 3 days of, not being able to sleep, both on you and Samantha?
So I'll be honest, for Samantha, it almost seems like it doesn't even bother her. Sometimes it's like she's the Energizer Bunny and she's just going. Some nights it's that she's literally just awake and can't sleep. Some nights it's that she's screaming and crying and the same thing, cannot communicate what's wrong. And so you're going through trying to figure it out. For me, it's important, if she's awake, I want someone paying attention, right? And then even if you're sleeping, let's be honest, if you have a child like this, and I'm a single parent, so I'm the only one there at night, I don't sleep the same as if someone has taken over her care, then I sleep like a rock. But when she's there and I'm in charge, I'm always sleeping lightly anyway. Mm-hmm. But I'll just give an example. I literally had done 3 days that I had no more than 5 hours sleep in those 3 days. Mm. The next night, the first time ever, Samantha's 13, the first time ever, I slept through a major seizure, a big seizure. And when I woke up, I saw the petechia all over her face, and I knew. I was like, oh no. So I picked up because I have a camera that always is videoing. I went through the camera, found it. It was a 10-minute seizure. Wow. And that was the moment I said, okay, never again. If I've missed that much sleep, someone else is in charge for at least one night so I can sleep. But as far as through the day, sometimes I feel like I can't even get out of bed, but I don't have a choice. I have to get out of bed, right? You can't just stay there. Yeah. But you do what you got to do.
Sure. Thank you so much. Who else would? Yes.
Hi. I think for us it's a combination of visual impairment and hand use, just because it would be, even though we're doing all these therapies, which are, whether it's eye gaze or, visual intervention, or we don't know how much she's processing. We don't know if she's really selecting things because it's just random, or is it because, we're assuming and we're hoping that she's selecting, Mommy, I want to read a book, or...
Right.
So, and that, I think the visual impairment also impacts the hand use majorly. So, they have to be fed, they have to be, provided with things, taken care of. And, even the use of switches. We work so hard on lighting the switch and placing it and the way it's done. And, sometimes, as families, you're just not sure. Right. Whether it's intentional or not. And, so whatever communication devices you need, there's that visual part that's holding you back. Sure. And eye contact, I think, is a major thing. I just want her to look at me and say, yes, no, just, with her eyes. But even that, we struggle with a lot.
Sure.
Thank you.
No, thank you. Yes.
I just wanted to briefly address the sleep a little more too, because Karen is completely right and I can connect with her. Sometimes my husband has to travel for work too, and I have Lena overnight every night, obviously. Yes. And after a few nights of very interrupted sleep, and we're lucky, she's had full nights of sleep before, but lately she does sleep 2 to 3 hour chunks, which is great, but sometimes not. And I realized that the next day, and especially the second day and the third day, I also don't want to get out of bed, but I have to. But I don't do anything that doesn't have to do with her. I change her, I feed her, she's absolutely taken care of. But I forget things sometimes, even things that have to do with her, I do last minute, and that's not my style. I haven't missed a therapy appointment for her yet, but I've missed other things for myself. The house hasn't been cleaned, maybe timely, or we have to order because I don't have time or energy to cook, or things like that. I don't feel like doing anything that doesn't have to do with her, and that's very distracting, that's very disappointing, that doesn't make me feel great, and I feel like I spend days in a haze where all I do is just watch her.
And is it similar where when she doesn't sleep that it almost is you can see no difference in her, or does that have an impact on her as well?
Well, I don't know if it has an impact because a lot of times, she sleeps when she feels like it, and she's up when she feels like it. Sure. So sometimes she'll sleep through the day, but we've had times when she didn't sleep through the night, then she didn't sleep the next day, then she, maybe slept half of the night the next night, and she was again awake. So it doesn't seem like the lack of sleep is what's affecting her. Sure. So I don't know that I can make a connection there. Okay. But I think overall, neurologically, it is affecting her because we know the impact that lack of sleep has on the brain.
Sure.
So whether she recognizes it or we recognize it in her behavior, I know that it's affecting her biologically. Sure. So I wish we could, and we've tried different things to help her sleep, melatonin. I know other parents have tried even harder medications, and they don't seem to always have an effect. So.
Sure. Thank you so much for sharing.
Thank you.
So I see we have a hand here, then we'll come to the front of the room.
My name is Cynthia.
Cynthia.
I'm going to speak to the topic that is probably the least glamorous that we all deal with every day from the moment we wake up, which is poop. So gastrointestinal and feeding problems are probably our daily struggle, and we have been on our journey with Olivia for 17 years. And what we are discovering, and we've known, but struggling through, if we don't have a healthy gut, which all of our children do not pass stool regularly, and constipation is an extreme problem, that does contribute to epilepsy and the amount of seizures she has, and it snowballs into a horrible storm. So literally our daily discussion is poop. How was it? Was it enough? I would give $1 million to have a regular movement every day for our daughter, and that is probably my top three were the speech, as has already been spoken to have a conversation and to help my child in pain, yes, where we can't discover what's wrong with you, and I can't help you. You're completely helpless as a parent, and that is probably the most heartbreaking for me. The daily management is the poop and global developmental delay, what we would do to see our child run again and understand. We know that we have a child trapped in that brain. Yeah. And when I can look in her eyes and she can soulfully look to me, and I know that she can understand some things, and actually mischievously. So that brings me joy if she does something that, something simple like hitting something and laughing, and if I can tell her, no, that's not nice, and she can smile a little bit, I know she understands me, but she can't communicate that. Sure. And we would like to bring that joy about.
Yeah, thank you. I'm going to bring the conversation back to poop, just to
Happily.
So we can understand, what this struggle looks like a little bit. Is this something? Can you maybe describe? Is this something that's cyclical? Is it a constant concern of being impacted, or what's the variability from day to day?
It's a daily constant. Mm-hmm. So we know if we can't get things moving, and it's a struggle every day. It's we have to stay on top of it. And her new regime, she just had a tube placed in to help with that. Sure. At 17. And when I say daily, I think we all understand it's a daily concern.
Sure. Thank you so much. We got a hand right here.
Hi, thank you so much. Miriam, and I'm mother to Landon, age 9, male. And I chose as our most burdensome to echo what a lot of people said in this room, gastrointestinal and feeding disorders. And I also kind of combine that with the aspiration factor. One of the panelists was talking about worrying about overnight vomiting. And to me, that's just something that, pulls away from sleep, but obviously it's just something that is incredibly stressful in the family. When my son vomits, it is something that raises the stress level in my family just through the roof. My husband and I just can't handle it very well. But my son has, from a GI perspective, not only does he have a G2 place, but he has ulcers, eosinophilus esophagitis, he has severe GERD, he has slow motility, he's got, he has to have a annual upper GI and lower GI scope, and they take a biopsy of his tissue to check for eosinophilus count, and he takes 4 different medications: Carafate, Nexium, Pulmicort ingested, and he has monitoring for active airway disorder, which is basically asthma of the esophagus. So when he does vomit or he has a wet burp, he will go into just really bad spasms in the airway, and it scares him to death. I mean, he can't breathe. He's got mucus that backs up because of it, and we have to get suctioning in place immediately. If this happens at school, they call me from work to come try to suction him because he doesn't have the proper, they can't provide the proper care for him at school to be able to suction. From a nursing perspective, the nurse suctions him pretty much every hour on this. So when we combine something like being, looking at having to deal with aspiration and the potential for any of these bacterial consequences to end up in his lungs, the vomiting, again, back to that, it really makes for a very stressful family situation.
And two follow-up questions. One is, how frequently is he having those vomiting episodes that you were describing? And have you noticed any change over time? Has that been getting worse, or has that been about the same for pretty stable for some period of time in terms of numbers or severity of the episode?
It's some really bad weeks. It's a couple times a week.
Okay.
The GERD, the wet burps that can trigger the vomiting, may trigger the vomiting or may just end up in GERD and wet burps, but it can be as frequent as a couple times a week.
Sure.
And it has, he's been on the ketogenic diet for about, out of 9 years of his life, he's been about 8 years. So if the ketosis is too high dialed up, he may vomit as well.
Sure, thank you. So I want to take us real quick to our next polling question, but we'll have some more dialogue after that. So if you can pull your phones back out. So this question, we've been talking about the symptoms and health effects, but here we want to know, what are the activities of daily life that are most important that your child is not able to do or do as fully because of CDD, so because of all of those different impacts that we were discussing. So here we'd like for you to select your top 3. Your options are A, walking, B, sitting unaided, C, using their hands to manipulate objects, D, feeding oneself, E, independence for most activities of daily living, F, nonverbal communication, G, verbal communication, H, having regular sleep patterns, I, social interaction and participation, J, attending school or having a job depending on their age, or K, some other activity of daily life that would be important to your child that they're not able to do or do as fully due to their CDD. And again, pick the top 3 activities that you view as most important that your child is not able to do or do as fully. Okay, while final results are trickling in, it looks like the activity that is most not able to be done or done fully by our individuals represented today is verbal communication, followed by nonverbal communication and just general independence for most activities of daily living. However, as a top 3 most important activity, pretty much all of our other activities listed here have been rated and rated highly by many of you. The lowest being having regular sleep patterns, attending school or job, and then some other activities that weren't listed. So one of the things that stood out to me from our panel discussion was that there seems to be a period of, albeit difficult, skill acquisition, so activities that are able to be done by your children. And then there also then tends to be periods where those skills that have been acquired are lost, and sometimes lost permanently. So in thinking about these important activities to you, I was wondering if anyone could share their experiences of whether these were of activities that are no longer able to be done, but perhaps that were skills or activities that could and were done in the past. So which of these things, to say it another way, were at one point gained but now lost? Yes, we'll come here and then we'll come to Amanda.
Hi, I'm Martha Boyles, and our daughter Elsa is almost 14. And when she was about 5, she had a major increase in seizures due to a medication change. And she used to be able to hold her sippy cup and use a straw. She was working, even though she has pretty significant cortical visual impairment, she was able to hold a spoon, use a brightly colored spoon, bring it to her mouth. We were starting to work on self-feeding. And she lost all of that during that period of intense seizure activity for almost a year. And so she's gained some back. We're just starting to get her to think about holding on to a spoon, has no interest whatsoever in using a straw again or holding on to the sippy cup. So everything has to be given with fluids, either in a kind of jello format, or she will drink water, but we have to use a spouted cup, more like a baby cup, but she is drinking that. So she has regained quite a bit, but what took about 4 weeks of intense seizures to lose has taken us close to 8 years to regain even close to it.
Wow, thank you. Let me just bring that over to Amanda.
So I'm going to speak to the social interaction and participation, and I'm also going to say the behavior slide before very much relates for our family. When Ava was younger, it was a lot easier to get her out into the community. She was smaller, she was quieter. People were more tolerant of some of the behaviors that Ava has developed over the years. I think about every one of those behavior aspects I could attribute to her, and society just isn't real accepting of our children. So I think that's an additional burden that is very hard for us to, talk about, or that probably gets overlooked in the conversation. I'll give you an example. We go to a Mexican restaurant. Ava loves enchiladas. And this is a restaurant very close to our home, and they love Ava. Probably 2 times I have overheard people complaining to management about Ava being loud. And management has kind of said deal with it or go, but I do know that people aren't always as accepting of some of the teeth grinding. There's many different behaviors that can be very distracting, especially in public.
Yeah. So has that kind of I guess a negative feedback loop, has that resulted in fewer social outings?
It does. It's hard to deal with. I mean, I even at my own North Campus of my local hospital have had go-arounds with nurses. She'll bang her head on walls and do things that if I'm the only caretaker in there, I'm not always in control of some of the things she's doing if I'm helping do something else. So, even in a medical institution, sometimes they're not quite aware or capable of handling these types of children and their behavior. So I think it's a very big chunk of what keeps some of us at home, especially as our kids age.
Sure. Thank you so much. We have a hand right back here.
Hi, my name's Carol Ann. I'm from England, and I'm mum to this little bundle of joy who is very loud and happy today. So Amber's not really regressed in at all, really. Okay. But one thing that we do struggle with is just to hop back to sleep. When she was little, she used to go through phases where she wouldn't sleep for days, or it seemed like days on end. And then things really, really improved. But just lately, probably within the last 6 months, she can go for at least 4 nights a week where she's having an all-night party. And it's not just an all-night party, it's an all-night and the following day before she then crashes. We'll catch up or rebound for 24 hours, and then we'll go on another 36-hour jolly trip of her own. And I think that that's one of the things as she's got older, so she's 14 now, she's not started her periods yet, and I think that that's probably one of the reasons why sleep is a little bit more impacted as she's moved into puberty. Okay. The other thing is she started a single-use compassionate trial at Loren earlier this year, so we're into about 4 or 5 months of starting that drug, and I think since it kind of coincided with that, so I'm not sure if it's a side effect of the drug that actually her overall mood has improved, and because her overall mood has improved, she's just wired quite a lot of the time, or whether it is because she's, you know, just about to enter those womanhood years. Mm-hmm. The other side effect, obviously, of sleep, and I was going to talk in the previous session, is that I actually ticked the behavioural difficulties. So a lot of the sleep problems that we have are related to hyperactivity. So she can't switch off, and we kind of know at 5 o'clock in the afternoon if she's kicking her legs and thrashing around and laughing like somebody's told her a really unfunny joke that, you know, we're in for a rough night. And when you work full time, that is a major issue.
Sure.
So yeah, I just wanted to share that, really.
No, that's very helpful. Thank you so much. I think we have time for one more comment before we take a break. Yes?
Thank you. Hi, my name is Karen Diller, and our daughter is Carly. Carly is 23 years old. We did not get a diagnosis until she was 14. But the one thing that she loved to do was attend school. Mm-hmm. I think one of the saddest moments was to see her graduate. Mostly because I knew that we were going to be her life. She no longer had friends. No one too that was similar to her. We are lucky enough to have nursing care for a few hours every day, except weekends. But we have one nurse who will take her to Walmart or someplace, and so she does get to have some socialization. However, what happens when she has gone to the bathroom in her diaper? Well, when you have a little one, it's not too hard to change them in the bathroom. But when you have someone who's 23 years old, 80 pounds, even though she's not a big girl, where do you change her pants? Those are some of the most difficult things for us right now.
Thank you so much for sharing that.